depress the release of that, that means you're not going to have fever. Like this is a pyrogen. If you reduce its amount, that means it's not going to change the set point, temperature set point in the hypothalamus. So all these effects have anti-inflammatory, cause the anti-inflammatory effects of cortisol. So what about if even if the inflammation already occurs, it seems that cortisol also can reduce the severity of the inflammation. And we use cortisol very often with rheumatoid arthritis, which is a chronic problem, as well as rheumatic fever and acute glomerular nephritis. We use cortisol, and they are very effective. Again, they stop all the process of inflammation. In this case, the inflammation response of the body, which we listed, the 5 things that happen, is more damaging to the tissues than the disease itself. The response of the body is really the main problem. However, and we use it very effectively for arthritis as well as acute glomerular nephritis, and it's used quite often for that. And you need to keep in mind, though, cortisol does not cure the problem. It only prevents it from kind of becoming more severe by stopping the inflammatory response. Cortisol also seems to block the inflammatory response to allergic reactions. This is antibody-antigen-antibody reaction. Okay, and again, this can be responsible for the effect. This, when that happens by itself, it can cause damage. Therefore, cortisol is also useful against these antibody-antigen responses. And for example, we use cortisol, if you remember from our cardiovascular system, we use cortisol to prevent anaphylaxis shock. And it's practically one of the few drugs that can be very effective when you have somebody with anaphylactic shock. And it probably has to do with its, its effect on the allergic response. Also, it has, again, we are talking about its anti-inflammatory effect, but we know also that cortisol has an immunosuppressive effect. Yes, sir?
Doctor, when you're saying anaphylactic shock, do you use cortisol? Do you use
anaphylactic shock.
Yeah, do you use cortisol or cortisone?
Cortisol is the main glucocorticoid in humans.
Yes.
It's also called hydrocortisone. Okay, the one you're talking about is cortisol. Yeah, you can use that, but it depends upon how. Remember, when you compare a lot of these medications, even if they are synthesized or unsynthesized, we usually compare them with cortisol. So if you need to use a more effective or
dihydro.
Yes, you can use, you have a choice, so it depends upon how much you need in terms of depressing or suppressing the inflammatory response. But you can use synthetic ones, and we have a lot of them, and they're quite available. Any other questions? Okay. In addition, now remember, also, in addition to suppressing inflammation, cortisol is also is an immunosuppressant, and sure enough, it decreases the number of eosinophils and lymphocytes in blood. Okay, and so it is, because of that, we use it as immunosuppressive drug in terms of, whenever people, whenever you have a heart transplant or a kidney transplant, we have now. In the olden days, we didn't have too many immunosuppressive drugs, but now we have a number of them, but still we use cortisol. And of course, what was your name, Ammar?
Abdullah.
Abdullah. Ammar is it? Yeah, Abdullah.
Very big difference.
Yes. Okay. But now if you give somebody cortisol as a clear result, as a clear effect of suppressing the immune system, if they will have a fulminating infection, as even if they have like tuberculosis before.
This is how people will die.
Yes, because you have to be careful now because you want to stop the inflammation, but you don't want to immunosuppress them so much that they will die from some other disease that they might have that's lurking and waiting till they become immune compromised. Again, that's when, with glucocorticoid, you have to understand what's going on. It's not, one-way street. There's always a price for what you're doing. It's anti-inflammatory effect versus immunosuppressive effect. You have to weigh the benefit and risk between the two. So how does it work? Glucocorticoid, how does it do all that? Well, remember from the first lectures we took, we said that there were almost, not three, but let's say two types of hormones. One that are proteins, they act on receptors that are located in the cell membrane. And these receptors usually have 7 transmembrane domains, all of them that we have known. All these that function via a G protein mechanism, we have identified by now like 1,000 of them. They all have 7 transmembrane domains. There's something about that. But cortisol is a steroid, right? And steroids, Salman, where do they have the receptors?
Cytoplasm.
In the cytoplasm or in the nucleus. Let's say cytoplasmic, and they're not on the cell membrane. And that's how cortisol acts. It enters the cell, and it can go easily through the cell membrane. It binds to its receptor. Its receptor, the whole complex diffuses into the nucleus and stimulates the formation or repression of transcription of certain proteins as well as enzymes. So it's a very typical steroid mechanism. Okay, so now you have a lot of steroid on board because you have an infection or a trauma or a surgery or somebody broke one of your bones. And then cortisol does whatever it does. And then, of course, it's like everything else. You remember we said, يا محمد, شباب مبسوطين ورا ولا? This is good stuff here. Okay, so you have, as with all hormones, we have negative feedback. This is with the cortisol, the one hormone that really affects the release of cortisol is which one? ACTH from the anterior pituitary. Well, ACTH can be also stimulated from the hypothalamus by adrenocortical releasing factor or a hormone. So you have negative feedback as cortisol goes up. It relieves the stress. I know very often we release a lot of cortisol when we're stressed. This release of stress sends a message to the hypothalamus, which really reduces the release of the stimulating hormone or factor, and therefore ACTH goes down and cortisol goes back to normal. You can also have a negative feedback loop directly between the cortisol and the anterior pituitary. That's where ACTH comes from. So it's you probably have both of those. But again, it's a very typical negative feedback mechanism. Well, now if somebody took blood out of you each half an hour or 1 hour and tried to determine your concentration of cortisol over a period of 24 hours and draw that on a curve, that's what you get. Apparently, it's maximal at about 8 o'clock in the morning. So it goes up, starting from the lowest level you have at midnight for some reason, and it goes up till about 8 o'clock, then it starts going down. So this is the kind of levels of cortisol that you will have over a period of 24 hours. And again, it's a cyclical change. And probably this has something to do with the hypothalamus cycle or the hypothalamus anterior pituitary cycle. But the point we are trying to make here, it's not like a constant level all day. It varies during the day. Somehow, for some reason, it's maximal in the morning and minimal at midnight. Okay? Okay, well now, يا محمد خلفوا بعد خلصتوا. Okay. Now, there is another thing that is mentioned in the book. I just want to mention it for the sake of completeness, And it's kind of some chapters, especially in endocrine, have a lot of biochemistry, and you will see we'll get into that when we talked about insulin and glucagon. Even though I'm not a big fan of biochemistry, but I think.
Nobody's.
Okay, well, but what we will try to cover them, and from what I understand, some of our students are having problem with biochemistry. So if that's the case, we want to give them some information that, whenever we can. So maybe we will not have this problem in the future. Apparently, the ACTH one, again, remember that comes from the anterior pituitary. Apparently, it's secreted with another hormone that is large protein, and it's called pro-opiomelanocortin, POMC. POMC, we would have to say that every time we mention this hormone. And this hormone also is secreted with other hormones from the anterior pituitary. And these include melanocyte stimulating hormone, which we've heard about, that has something to do with feeding as well as pigmentation. And another two hormones that are listed right here, but under normal circumstances, these are not secreted in large amounts. Okay, so we don't worry too much about them. The problem comes if the rate of secretion of ACTH is very high, as we would have in a person who has a problem with control of cortisol, such as in Addison's disease, then you will have a lot of these hormones also, or these other large proteins secreted, and then you might have amounts that become, that can have a significant effect. So you have to consider them when you have an inappropriate release of these hormones.
Doctor?
Well, now, yes?
Does POMC also make ACTH?
Yes.
So it's like a positive.
This is POMC. See how big it is? I don't know how that's big. Okay. And this is, remember now, this is as it comes out of the pituitary. Okay. And the pituitary gland has this prohormone convertase, PC1. So PC1 is in the pituitary. And this is a convertase, so it can cut this or splice this protein at different points. And as it does, remember, if you split it right here, you will have an N-terminal protein and this joining protein, which we don't know what it does. If you splice it here and here, you will have ACTH. But now, if you splice it at different places, you will get a total different hormone. So PC1, this is one, PC1 exists only in the pituitary. Okay, and remember now, these convertases, they can act at a certain point in these hormones, large hormones, prohormones. However, the PC2, which exists only in the hypothalamus, is the only one really that can make ACTH. Okay. So you have, like I said, what you make out of this pro-hormone depends on the availability of enzymes and exactly where are these enzymes going to splice the large protein. Well now, PC1 is contained in the pituitary and PC2 is contained in the hypothalamus.
That doesn't make
What
sense.
produces no PC2s?
ACTH would not be produced by PC2, correct?
No, it
What? What's the question?
ACTH.
Yes.
You said